Hey, welcome to the Next Society's webinar on elevating nurses. We're really so glad that you all could make it. We have a great list of presentations and speakers joining us today. We're really honored to dedicate this webinar series to Amari. Amari's mother will be joining us and sharing her family story in just a moment. I also want to say thank you to Engage, Grow, and Thrive for partnering with us on our summer webinar series. So as many of you may know, the Next Society recently partnered with Cincinnati Children's to host the NEC virtual sessions that took place in conjunction with NEC Awareness Day, which was May 17th. So this just happened about a month ago. And we have a number of recorded videos and a summary that you see here available on our website. I believe Erin will be sharing the link in the chat box to this resource and to others. And so we're going to use that live polling tool again. So if you go to the chat box and you click the link, you should be able to answer this question and your answer will show up here. So did you attend the NEC virtual sessions? Maybe you watched some of the videos. We have the recording of Dr. Bianchi's presentation as well as Professor Nina Modi's. We are putting together a highlight video that will be shared soon. Wonderful. So a few people missed it. Someone watched the videos. Wonderful. Glad to see a lot of people joined us. So I love this quote from Dr. Sheila Gephardt, who serves on the Next Society's Scientific Advisory Council. If nurses don't have a voice, then parents don't have a voice. And we couldn't agree with Sheila anymore. I mean, it's so true. So we're really excited to help elevate the voices and opinions and perspectives and expertise of our nurses, and therefore our parents and community as well. So here is our list of speakers today. I'm Jennifer Canvasser. For anyone that I haven't had the pleasure of meeting, I'm the founder and director of the Next Society. I lost my son Micah to complications of the disease. We're going to be hearing from Nicole, who will be sharing her daughter Amari's story and their experience with NEC. Jenny will be presenting on context in the environment, and Jenny also serves on the Next Society's board of directors. Mindy will be sharing advocacy at the bedside and different tools. Sheila will give us a presentation on communication, and Jill will focus on her story and her experience with her own NICU, and then Adrian will share some of the long-term outcomes and ways that nurses can help support families with the long-term complications such as NEC. So we're really excited to hear from this team today. For anyone who is new to the Next Society, welcome. We're so excited to have you. The Next Society is a 501c3 nonprofit organization that's dedicated to building a world without NEC. We bring together clinicians, researchers, patient families, and other diverse stakeholders to advance research, education, and advocacy. So thank you, welcome. We're really excited to be here with you all, and we're excited to get back to in-person conferences like this. These pictures are from our 2019 symposium at the University of Michigan. So we hope that our next meeting that we have together will be able to be in person. So just a quick disclaimer before I hand it over to Nicole to share her story. The Next Society and our faculty, we're not providing any medical advice, and everyone's views is separate from the Next Society as an organization. So just wanted to quickly introduce Nicole. Nicole is a patient family advocate with the Next Society, and she has been advocating for NICU families for a long time, and I'm really excited for her to share her daughter's story with us. So I'm going to hand it over to Nicole.
Good morning, everyone. Thank you for joining us. I'm really excited to be a part of this. This is a fantastic thing that the Next Society is doing, holding the webinars. And I want to thank you for even asking me to join, Jennifer. So I appreciate it and I'm honored. My name is Nicole, and my daughter, this is her story. This is a quick rundown of her story. I found out actually that I was pregnant at 14 weeks. At 19 weeks, I found out that I was pregnant with twins, and I had lost, for the sake of this conversation right now, twin A. And at that time, I found out that twin B might still be viable. And I was sent home to have a more comfortable miscarriage. Well, that miscarriage never happened. And I ended up having my daughter Amari at 25 weeks. She was 1 pound and 14 ounces. So I didn't, the first child, not knowing what to expect with the preemie, not knowing that hey, I can't go with my kid because she got life flighted to a major hospital, and I'd had her at just a local hospital that I was passing by because I, was in labor. And so I wasn't even able to see her until after 2 weeks after she was born. So my whole story, her whole story it's filled with such trauma, but joy and perseverance. So like 4 months after, 4 months into her NICU stay, she just did not look okay. The one day, just a random day, I walk in and something's wrong. And I don't know what it is, but I know that something is wrong. Um, that day I hunt down, three of the doctors that are on her team and told them I'm looking at something, and I can't name it, I can't place it, but something is going on with her. Can you please take a look at her and not just her chart? And all three times that I went to all three doctors, I was dismissed. And it kind of like did something to me, because it's like, I know that I'm a first time parent, and I know that I may seem a little frantic, but there is something wrong. And I know that, and I don't know how I know that, but I know it. So all day long I spend trying to get these doctors to listen to me, and nothing works. So night shift comes, and I have a very, very good connection with the nurse named nurse Misty. And it was her night shift, and she was coming in, and I just looked at her and said, can you please, please, please check her out and see if something is going on with her? And her and I bonded all this time over our grandmothers and recipes, and just life. She's significantly older than I was, but she just looked at me and, you're an old soul, and you have maturity on you, you can do this. It's going to be hard being a preemie parent. However, there are light spots and brights and moments that you will be able to handle it. So having her as an encouragement every day that I came in, knowing that she never saw any other family that came in for my daughter other than myself, like that is what I needed. So I kind of figured that if I could get her to get my daughter into x-ray, to get her into just take a look, that her doing that would mean that I'm not crazy and something is really going on with my daughter. So I pleaded with her, can you please just check her out? Please, can you just get someone to get her into x-ray, to get her into whatever test she needs, because something is going on. She looks at me and she says, okay, I'll make you a deal. You get out of this hospital and I will sneak her into x-ray. And I kind of look at her and I'm like, well, I don't know, because like here it is, you're this woman who works here, and you're gonna risk your job sneaking her into x-ray. You don't even know me. What if this is just a ploy to get the crazy lady out of the hospital because you guys need a break? And so, but on the flip side of that, what if she's serious and she really gets my daughter into x-ray, and she finds out something, what is actually wrong? And she looks at me and she's like, I'm serious. I'll make you a deal. If you leave this hospital, you go back to the Ronald McDonald House, I will get your daughter into x-ray. I will call you if something pops up and something's wrong. But if nothing's wrong, then you got to stay at the house. And I just looked at her and I said, okay, okay, let's do it, deal. So I set my watch and I'm like, okay, look, you got, a couple hours to tell me what is happening with her. And I'm back on my way to the hospital. So 45 minutes after I left, she calls me and she says, you have to come back to the hospital right now. Okay. I head back over to the hospital, and I head up to the third floor where the NICU is. And she looks at me and says, and all the doctors are standing there, and they all look at me and say, hey, your daughter has NAC. Wait, what? What do you mean she has NAC? There's something wrong. She has NAC. We have to take her into surgery right now. And my first thought is, I've been asking you guys all day long to check my daughter out. And it takes Nurse Misty to sneak her in to do it. Now, has she not done that, where would my daughter be right now? Has she not snuck her in there? Has she not listened to me? Where would she be? What would happen? And as I'm going through my mind, getting ready to give all of them a piece of my mind, like I just stopped, because if these are going to be the last moments with my child, because I don't know what they're going to find once you get into surgery, then I don't want my last moments to be filled with giving my words and my energy to people who really could have cared less. So I'm going to spend my time and take all my energy and pour it in my daughter right now before she goes into surgery. Thankfully, when she came out of surgery, they said that she didn't have to be put on a colostomy bag, and that her recovery should be fine. But because she was a preemie, it's 50-50, and we just don't know. So fast forward, and she is being discharged and she's going home, and it's a little, she's a year, and we get home and no one says, hey, because she had NEC 4 months into her hospital stay, now that she's a little over a year, these are the things that you may run into because she dealt with NEC. No one said any of that. So, I had to deal with a lot of projectile vomiting days, a lot of food discoveries that it was like, oh, okay, well, instantly she's, having some symptoms of, okay, she can't eat that. She can't do this. She can't do that. And these are all things that I wish I would have either known to ask before she got discharged, or would have just been given the information upon discharge, or upon, those first few months after discharge. That way I knew what I was dealing with when I went home. The good part about it all is that I kept up and kept in contact with Nurse Misty. So I did have the support that I made a support team and kept this support team for myself with all the nurses and the doctors that I had grown to have really good relationships with. So I want to thank the Next Society for having this webinar on elevating the nurses, because had it not been for a nurse listening to me and just realizing that these are not the frantic pleas of a first-time mom, then I don't think that my daughter would be here. So thank you, nurses, for all that you do. Thank you. Even though there are times where you feel like you are not heard and you are not listened to and you are not appreciated, trust me, from this preemie parent, thank you. You are appreciated. Thank you, Jennifer. Thank you, Next Society.
Thank you, Nicole. Thank you so much for sharing Amari's story. We work really hard at the Next Society to keep babies and families centered in all that we do. And it's stories like yours, Nicole, that reminds us why we're here and why we keep pushing and advocating for a world without this devastating disease. So thank you. All right, we're going to hand it over to Jenny to share her slides. So Jenny, if you want to pull yours up, and we're excited to hear from you.
Okay. Can you see and hear me?
Yes.
Okay, great. So thanks for inviting me. I'm Jenny Quinn, and today I'll be talking about context and why it matters in quality improvement and our collective goal of one day building a world without NEC. As a caveat, there's an entire field of research called implementation science, in which context is often studied. The material I'm going to present today is really just the tip of the iceberg on the concept of context. Further, I have nothing to disclose. So to give you two definitions here, the NIH defines implementation science as the study of methods to promote adoption and integration of evidence-based practices and interventions into the clinical setting. When we talk about context, we are describing the different circumstances or unique factors that surround a particular implementation effort. There isn't a singular operational definition of context in the literature. However, in its simplest form, context can be described as everything other than the quality improvement intervention. So it is often cited in the literature that it takes roughly 17 years for 14% of original research to get implemented into clinical practice. What I really want to highlight here is that it can take an average of 9 years to fully integrate research into clinical settings following publications, systematic reviews, meta-analyses, or recommended clinical practice guidelines. The field of implementation science seeks to close this gap between what we know, which is the research, and what we do in the clinical setting. So context is a dimension identified in several implementation science frameworks, such as the CFIR, PRISM, EPIS, and IPARS frameworks, to name just a few. Context is a dimension, oops, sorry guys. I seem to be. So context is a dimension, oh, I apologize. My slides are getting a little wonky here. Okay. On this slide here, I'm providing the full names of the 4 frameworks supporting literature and their associated websites. Across the 4 implementation science frameworks I previously displayed and other frameworks in implementation science, context is a frequent domain in each of them. Similarly, elements of context across these frameworks are consistent and include leadership, culture of the unit and its learning environment, availability of human, financial, and technological resources, evaluation and feedback processes, and the ability to embed or hardwire the practice or process change. Nielsen and Bernardson recently published in 2019 a scoping review in which context was analyzed in 17 implementation science frameworks. The authors concluded that accounting for the impact of context is necessary to explain how or why certain implementation outcomes are achieved, and that context is considered responsible for study-to-study variations in outcomes. It's important to acknowledge that there are different context factors that influences quality improvement work within NICUs. This even goes down to individual or personally unique context factors, such as our beliefs and attitudes. This is the very reason why something may work well in one NICU, but not in another NICU. Identification of context factors and local adaptation is necessary for successful implementation of quality improvement initiatives. For example, in one NICU, there may be good nursing leadership, however, suboptimal physician leadership, and the nursing leadership may have the capabilities of supporting quality improvement with the necessary resources, but without some of the other context factors. Then what happens is engaging and implementing in quality improvement work will be a challenge. In another NICU, they may have engaged nursing and physician leadership, a good culture of inquiry and continuous learning, as well as periodic review of potentially better practices. Yet they could lack the resources, mechanisms for evaluation and feedback, and challenges with hardwiring processes. So in this particular unit, a culture of inquiry is a mindset, but they may fall short with efficient implementation and sustainability of changes. We also need to recognize that context is dynamic and constantly changing, which does necessitate frequent evaluation of current context factors and ongoing local adaptations. So what role does nursing play in quality improvement in context? Well, first, in a nutshell, standardization is a fundamental starting point in quality improvement. Once a process or practice has been standardized, data can be more accurately measured and evaluated. With standardization, there's fewer confounding variables, and this results in more robust outcomes. Now think about the context in your unit. For example, do you often hear this is the way we've always done it? What is the culture currently like in your unit? Is the decision-making process transparent and collaborative? When embarking on quality improvement or unit or hospital initiatives, is staff provided the necessary human, financial, and technological resources? Are practice or process changes easily embedded or hardwired? Or do you often find that things drift and you go back to the old way of doing things? Additionally, do different disciplines work well together? So nurses play a fundamental role when we think about quality improvement and context. Nurses function in both formal and informal leadership roles. Formal leaders would include the chief nursing officer, department director, and NICU manager. Informal nurse leaders are those nurses we view as clinically competent and recognized by their peers as experts. Informal leaders could also be unit champions and advocates, and they are usually the innovators or early adopters of change. Formal and informal nurse leaders have an enormous impact on unit culture, as well as the ability to create a psychologically safe environment. Additionally, as nurses, we really do need to be challenging the status quo, assessing whether clinical practices or processes are evidence-based. Nurses are an integral member of the healthcare team, and therefore we need to engage and support QI initiatives, work outside of our silos, incorporating teamwork, collaboration with other disciplines. A controversial practice many NICU nurses are familiar with is gastric residual checks. Many NICUs are going away from this practice as the evidence doesn't support that residual checks alone predicts neck risk. If your unit does check residuals, a potentially better practice is to have a standardized guideline in place. Some questions to consider in the guideline could be at what percentage or volume is considered abnormal. Are gastric contents refed or discarded? If there's green discoloration, but a normal exam, what happens then? If feedings are held or stopped, what is the practice of resuming feeds? Without standardization, there is variation in clinical management, which in turn can result in nutritional and neurodevelopmental deficits. The California Perinatal Quality Care Collaborative, or CPQCC, has put on its website a recently revised evidence-based nutritional toolkit for the very low birth weight infant. This toolkit offers potentially better practices that were developed from peer-reviewed literature. And two examples that I've included here are Drs. Lake and Dr. Riskin and their respective colleagues. Each section offers background, rationale and goals, recommendations, guidelines, and algorithms, as well as quality and process improvements and outcome or process measures that you can readily evaluate. In the enteral feeding chapter, a potentially better practice is to develop standard definitions of feeding intolerance with specific reference to actions or inactions based on gastric residuals, changes in abdominal exam, and presence of bloody stools. A quality or process improvement is to document reasons for withholding feedings, and a process measure would be the number of feeding interruptions. Now I'm going to transition and touch upon how parents' voices are also affected by having an infant in the NICU. I reviewed several articles recently published and put together a word cloud of the various parental experience descriptors. Families feel depressed, anxious, powerless, and helpless. They also experience PTSD and fear, trauma, and sadness. Now imagine your local NICU context or your work environment, as well as the unit relationships that we have with our colleagues. Families not only can see, but they can also feel these local context factors, and this can impact the relationship we have with our families, as well as the delivery of care and patient outcomes. To further demonstrate the relationship of local NICU context and parent voices, Dr. Linden and colleagues published an article titled Parents' Perspectives on Navigating the Work of Speaking Up in the NICU back in 2017. In their mixed method studies, parents were provided a hypothetical scenario of lack of clinician hand hygiene and then asked about their ability to speak up. The authors concluded to engage parents as partners in safety, clinicians really need to acknowledge the complex social and personally lived NICU experiences by parents. One parent is quoted as saying that all of a sudden they were put into a position that you don't have control of the environment. And to hold your baby, you have to ask for permission, which is really difficult because this is something that they did not expect. Another parent stated that decisions were being made without their involvement or keeping them informed. And the authors stated in their article, which is quite compelling and actually difficult to hear, that although parents respected and valued the care provided by nurses, physicians, and others, they expressed concern that if they complained, a clinician could take it out on my baby or inadvertently cause harm if the conversation left the clinician distressed or distracted. So in closing, it is my hope that bringing some awareness and some basic understanding of context, as NICU clinicians, we can pause for self-reflection, consider our work environment and how we work together to improve various context factors, such as leadership, culture, social relationships, and teamwork, and creating a culture of inquiry. As NICU nurses and neonatal clinicians, we are at the bedside daily, and we have the opportunity to improve our work environment, the delivery of care, and our families' experiences, and you can start the work today. Thank you for your time.
Thank you, Jenny. That was a wonderful presentation. We're going to move over to Mindy, and Mindy's going to be presenting on advocacy at the bedside and different tools that are available to help nurses speak up and advocate in the NICU.
All right. Hi, my name's Mindy Morris, and this section right here, we're going to spend a little bit of time talking about a few prevention strategies and some daily advocacy practices to incorporate into care. And I have no disclosures that are related to this presentation. I am going to start by sharing a possible driver diagram for the reduction of NEC. And a driver diagram is simply a visual display of what drives or contributes to an issue. And I think it really helps to create that shared picture that can be seen by all team members. It begins with the smarting, and then it's followed by primary drivers. You can also add some secondary drivers. And then what I've included in this list is some potentially better practices that also are directed at the drivers. And we have a short period of time, so we'll only focus on 3 of the many opportunities that exist: mother's own milk, use of a standardized feeding protocol, and antibiotic stewardship. And these are key activities not only for nurses, but also for anyone else that works at the bedside. For each of these opportunities, I really think it's helpful to have a shared understanding of why it's important. And at birth, the gut is mostly devoid of bacteria, and the neonatal gut microbiome is reliant on colonization via ingestion. There are clear differences in gut microbiota between breast and non-breastfed infants. Non-breastfed have less microbial diversity, they have fewer bifidobacteria, and they have an abundance of pathogenic flora. A disruption in the gut microbiota is linked to NEC. Mother's own milk, it's associated with multiple morbidity reduction, not the least of which is reducing NEC. And of course, mother's own milk begins with colostrum, which you can see with the benefits listed on this slide, how important they are to NEC reduction. Mother's milk is rich in live beneficial bacteria, and another benefit is the provision of prebiotics or human milk oligosaccharides, HMOs. They support growth of the beneficial bacteria. So HMOs not only support the growth, but they also inhibit the binding of pathogens to host cell receptor sites. The pathogenic bacteria that contribute to NEC, they must adhere to the intestinal wall to cause damage. And HMOs deny the pathogenic attachment because the HMO occupies the receptor site. And you can see that in that picture on the slide. Although pasteurization of donor human milk destroys both beneficial and pathogenic bacteria, HMOs appear to be preserved. So donor human milk as a bridge to mother's own milk. The provision of mother's milk becomes especially important for the preterm neonate because, as you can see from the CDC data, the preterm neonate who's at greatest risk for NEC is also least likely to receive mother's milk. There are also lower rates noted for younger mothers, those of certain races or ethnicities, those with lower levels of education, or those that are unmarried. So even though it's a challenge for all mothers to provide milk during a baby's hospitalization, it's important to identify which mothers are at even greater risk. So knowing how colostrum and breast milk impact the microbiome development, and that that the microbiome is associated with NEC, then what can be done to prioritize this at the bedside? Well, one is lactation support throughout the NICU course. Colostrum as soon as it's available, and then that transitions to mother's own milk feeds via a feeding guideline. Also, skin to skin as much as possible. It's one of the most important components of care for many reasons, and it also helps to establish the healthy microbiome. Skin to skin helps to colonize the neonate with parent microorganisms, and that helps the baby build resistance against pathogens. And also, during skin to skin, even the most immature neonate tend to find their way towards the breast for either non-nutritive or some nuzzling at the breast. And the areolar skin can contribute to helping to develop a healthy microbiome. So encourage non-nutritive sucking in neonates of any age as much as possible, and especially in the first 30 days of life. The next key opportunity is the use of a feeding protocol. And this reduces practice variation, and it standardizes the volume of feeding initiation and advancement. Feeding guidelines or protocols have been shown in multiple non-randomized controlled trials to improve nutritional outcomes, such as achieving full feeding sooner, which then leads to fewer days of parenteral nutrition, which then leads to fewer central line days, and it decreases the risk of sepsis. Feeding protocols also decrease the risk of NEC. And this is just a figure from a meta-analysis that demonstrate the significantly reduced risk of NEC with the use of a standardized feeding protocol. So if you don't have a feeding protocol, then participate in the multidisciplinary developmental process of a feeding protocol. And if you do have one, review it to see if there are some opportunities to improve it. Some things that you might want to consider are that it's beneficial if you can standardize as much as possible in the feeding protocol. So add into the protocol at what volume of feeds fortifier is added, at what volume of feeds is a central line removed, but all of these tiny little steps to help standardization. You can find examples of feeding protocols in the literature, and the bottom line is there are none that are right or wrong. Any protocol is better than no protocol. The best protocol tends to be one that's developed upon the evidence, and this is an important and it's one that your interdisciplinary NICU team can agree upon and stick to using. Then once your NICU does have a consensus-based guideline, there also needs to be a process in place to review compliance to using it. So simply having a tool is not enough. You've got to make sure that it's reliably utilized. And that's that part of unit context and culture that Jenny spoke about. At the bedside is also a key position to advocate for the support of using a feeding protocol, because you have that knowledge that consistent use reduces NEC. And be sure to discuss and review this tool with families. It's exciting for families to understand the feeding plan. And this feeding protocol is something tangible where they can see that an actual plan exists. Another bedside advocacy key is judicious use of antibiotics. Most preterm neonates are exposed to antibiotics during their NICU experience, and many, unfortunately, have multiple exposures. Studies have demonstrated that antibiotic exposure is a risk factor for NEC, and it increases with a higher number of days of exposure. In one study, they found that patients that received a common antibiotic regimen had lower gut anaerobes within 1 week of therapy. And they also found that each day of therapy was associated with 16% lower gut anaerobes. The Joint Commission has established that antibiotic stewardship programs are a standard, but other medications increase the risk of NEC as well, such as H2 blockers. So even though right now we're specifically talking about antibiotic stewardship, it really applies to all medication stewardship. Many preterm neonates receive antibiotics for very good reason. However, they also receive a lot of empiric antibiotic courses. If we look at this study figure, it shows the duration of initial antibiotic therapy, and you'll notice that the highest peak is at 3 days of life. And previously, that was common practice to treat for 72 hours with empiric antibiotics and then discontinue the antibiotics with the negative culture. Now, many centers have transitioned to a 48-hour rule-out periods. And you'll see that that's represented as the second highest peak on these bar graphs. But pay close attention to the other bars on the graph. A treatment course of antibiotics for a positive culture tend to occur in 7 10, or 14-day regimens. And all of those are represented on this graph. However, the chart value is actually higher for the day following the treatment course. So at 8, 11, and 15 days. So clearly there are opportunities to decrease dosing of antibiotics. There's been noted significant variation in practice across NICUs, and there may be variation in practice within the same NICU. But clearly there is an opportunity to improve our antibiotic stewardship, which we know antibiotic dosing is a clear risk factor for NEC. So what are some things to consider in your practice at the bedside? Well, firstly, it's understanding and participating in the NICU antibiotic stewardship program. Are empiric antibiotics stopped at 48 hours in your unit? Is it a hard stop where it's automatic? Is there a need, is the need for antibiotics discussed daily in rounds? And does that include the need for other medications? So it's really important to discuss each medication daily in rounds and be aware of the risk that each medication offers, especially if it also pairs with the risk for increasing NECs, such as H2 blockers. Now, some of the components may not seem as intuitive for antibiotic stewardship. However, skin to skin is very important during this time frame. So although it's important every day, while a neonate is receiving antibiotics, skin to skin can help provide that positive bacterial colonization. And the same is true for human milk. Of course, mother's milk is most beneficial as it provides not only beneficial bacteria, but also HMOs. However, if you're using donor human milk, it will also provide the HMOs. And any volume of mother's milk or human milk volume during this time is an important benefit. Even if a baby cannot be on full feeds, that some volume of feeds will be helpful. And the preterm neonate receives multiple rule-out sepsis screens with labs and possibly starting antibiotics just in case during their NICU course. So can we avoid some of these antibiotics by more continuity of care from all clinicians that truly know that baby? And then let's not forget who really knows the baby, the most continuous caregiver, the parent. They are often the first to notice when something's not right. And Nicole spoke of this very powerfully. So let's encourage and empower them to speak up when they have concerns. And when they do voice those concerns, let's listen to them. So these are a few practices that evidence has shown reduce NEC, and they're all influenced by bedside caregivers. A diet of human milk, especially mother's own milk, standardized feeding protocols, and antibiotic stewardship. And then lastly, get involved. Bedside care providers are essential contributors in quality improvement initiatives, and they're also heavy contributors to being an active participant in daily rounds. Thank you.
Thank you, Mindy. That was a wonderful presentation, and thank you for calling out the importance of the patient family voice and story. We're excited to hand it over to Sheila. Sheila, if you want to share your slides, that would be wonderful.
All right, that was great, Mindy. I really enjoyed hearing that presentation, and all the presentations so far have been so amazing. And I just want to mention my role today is to highlight the research around necrotizing enterocolitis risk, timely recognition and communication strategies. And I'm coming today from the University of Arizona in Tucson. All right, so along that line, see if I can advance. I have a few disclosures and acknowledgements. I don't have any specific conflicts of interest, but GutCheck, which we'll talk about in a minute, is available on the NextZero website, thanks to Ms. Christina Wiles and Mr. David Salea here at the University of Arizona. We've had several funders who have been amazing supporters of this research. And I also want to recognize Dr. Shelley Fleiner and Banner Health, who were critical contributors to the refinement of GutCheck, which is just one neck risk index. So to start off, I'm going to give this exemplar of non-specific communication of concern when symptoms arose. So this came from a nurse. We did several interviews, and this particular nurse shared her story. She said, I had one who, well, it actually wasn't my baby that I was taking care of. And she tells the story of how the baby was in her pod and the nurse went to the other side of the unit for a moment. And she says this baby had been breathing hard all night long, kind of irritable. She had another Brady, so her heart rate dropped. So I went over and she was gray and her belly was really large. So I called the nurse over and said, just FYI, your baby doesn't look so good. So she came over and she called the doctor and she checked, the girth had gone up like 2 centimeters and there was no residual. So she called the doctor and just let him know. And he said, just go ahead and hold that feed and just reassess later. So thinking this is probably somewhat in the middle of the night. The next care, she still didn't get a residual and the baby had stooled. It didn't look any different than it normally had. So he said to go ahead and feed, and just all during the night, this baby was really lethargic. And the next morning, the oncoming nurse called because she looked worse, and they ended up doing x-ray and she had perfed and she actually coded down in the OR. So this is actually a fairly typical narrative of a nurse who had identified something as being not quite right, and then made a communication to the physician team, and really had the baby had just kind of continued to get worse through the night. So, we know that our babies are vulnerable, and we know that they have individual risk factors, but we often don't think about their vulnerability related to our organizational patterns of caregiving. We also know that there are NEC risk factors, in that this concept of risk awareness and symptom recognition can be very variable from nurse to nurse, from physician to physician, from nurse practitioner to nurse practitioner, unit to unit. There's a lot of variation in our awareness and actions related to risk awareness. We need communication systems. This is, the ability to talk to each other that are bias-free and convey belief and trust. Just broadly in healthcare, we know that about 70% of sentinel events are the direct result of communication failures. So we wonder, how does communication inadequacy, so to speak, impact timely recognition of NEC risk? But if communication systems work, do we get to timely recognition? And if we have timely recognition, does the team act cohesively to diagnose and treat? And I just show this continuum because there are a lot of places in this process where things can go wrong. And so the idea with NEC risk scores is that we want to make the process a little bit more reliable. And when I say reliable, I mean repeatable, consistent, applicable to all babies. One of the mottos of our team is, so that every baby everywhere can get the best evidence-based care every time. So are we doing this in a way that's reaching every baby every time? So this idea of a reliable system is pretty critical. So in the published research evidence, there have been a number of necrotizing enterocolitis risk factors identified. And I just point you to a couple of key papers. I recognize Samuel's, Rose and Patel and Cotton, and then I could also throw in the risk state of the science that I wrote. So in those reviews of the published literature, these are the sorts of risk factors that are commonly described. Non-modifiable risk factors include being Black or Hispanic, being low gestational age, very low birth weight, small for gestational age, or growth restricted in utero. If the baby's mom had an infection or had a prolonged rupture of membranes, if she abrupted during labor, or if there was cocaine use during pregnancy. Also, if the baby was born with some sort of a congenital anomaly, especially a ductal dependent congenital heart disease. Later on, if the baby developed a patent ductus arteriosus, and then if they had anomalies like gastroschisis, and then if they were outborn, which meant that they were born in a hospital and they had to be transferred to another hospital to get the appropriate level of care. So those are all the non-modifiable risk factors. That's the vulnerability factors that come with that infant. But then we have a host of modifiable risk factors, and that's what Mindy just described in talking about the driver diagram and looking at, what are some of the actions that we can take. And we do know also that we have a few things that reduce risks. So if the mom got antenatal steroids, if the baby's exposed to sufficient volumes of human milk, if the unit used a feeding protocol, and then if probiotics were given. So those are the things that impact NEC risk. And I show this because this is a nomogram of the time of neck onset by gestational age. That is a mouthful. But I show this because in my personal story, looking at neck risk and having a baby develop neck and telling the physicians there's something not right about this baby, never in that conversation did I ever think to myself, is there a peak onset time that this baby's most likely to develop neck? And so this is probably the best example I have that demonstrates the median onset time for neck by gestational age, and also shows the variation in that median onset time. So the physicians that I worked with at that time when I had the neck cases, they told me, Sheila, we just have to be very worried. And I thought, well, how can we be very worried all the time? So is there a time that I'm supposed to be more worried or less worried? So this is kind of an idea of how can we kind of focus our worry. But if you look at these nomograms and these error bars, that's the strings around the little centers, there's a lot of variation in when these kids get neck, but generally it's at least 2 weeks after birth, and it can be up to 45 days or later after birth, depending on gestational age. But we can't just say we have to be worried all the time. So what can we do to help focus our worry? A number of neck risk and recognition tools have hit the market. And of those, we have eNeck, which was developed by Chris Wetzel and tested later by Jane Naberhuis. We have NeoNeeds, which was developed by Fox. We have the Hero monitors that have been shown to detect some variation before a clinical diagnosis of neck. And then we have GutCheck Neck, which is the score that I developed and have continued to test in my research. I'm going to talk about GutCheck Neck just because I know it the best, but in an individual unit's decision to adopt a risk tool, my recommendation is pick one that fits your needs the best and use it and make communication about neck risk and concern when signs develop more repeatable, reliable, and consistent. But I'm going to talk to you about GutCheck Neck as an example. So GutCheck Neck was developed over several phases. We first started with a narrative review, which is the state of the science of neck risk. You can find that online. Tried to figure out which neck risk factors matter most, and we came up with 66 unique factors. That's a lot of pieces of information to hold in one's mind as you're continuously being worried for 45 days of an infant's life. So we're trying to figure out, like, how can we make this more of a score? And we asked experts, like, which of these risk factors are the most relevant? And we got to 33 consensus defined most relevant risk factors. And that's what is contained in the long GutCheck Neck version, which can be used for all infants. It's pretty similar to the long version of eNeck with a few minor variations. Study 2 involved taking those risk factors that were in the long version and figuring out what mattered most and using a statistical model to do that. And then to see if we could test the prediction. And that's when we got to the short GutCheck Neck version. And that is this tool, which is on the left side of your screen. There's 9 risk factors and 2 risk reducers that are in that score. And we quantify low, moderate, and high risk and very high risk. And one of the things that we did in our program of research was we partnered it with a structured communication tool, because we realized that it wasn't just the risk recognition that we needed, but we needed some clear way to structure the communication. And if you'll notice in the SBAR tool on the right side of the screen, one of the triggers for calling, a concern into the physician is the parent concerned. We wanted to include the parental concern as part of the assessment, because the members of our team recognize that sometimes the concern comes from the nurses, sometimes the concern comes from the parents, but it usually does arise from one of those two. You can download these for free on our website at nexzero.nursing.arizona.edu. So we then tested GutCheck Neck to figure out how often we needed to score it and if it related to clinical signs and other measures of clinical deterioration. We found that we could score it every 12 hours and that the early, which was the 72-hour of age score, did predict the worst neck, and that clinical signs were present up to 36 hours before diagnosis, especially in the worst cases. and that the gut check neck score did correspond to the SNAPI-2 and the Pew scores, that adding those scores to gut check neck did not improve the ability of gut check neck to tell the difference between the kids that were going to get sick and the kids that didn't. This depicts, how much in advance of a neck diagnosis were clinical signs identified. And if you look at the left side of the screen, this image was put together by Kate Gregory, looking at my study as well as Bob Christensen's study that looked at early clinical signs before a neck diagnosis. And both of us showed distension up to 36 hours and a dusky abdomen. At 24 hours, we noticed these clinical signs. Blood in the stool is pretty much a red flag that everybody gets. You call the physician and say there's blood in the stool. Okay, let's get an x-ray. But what people don't realize is that blood in the stool is actually not a predominant clinical sign in neck. It doesn't happen in all the cases. In fact, it's more like 20% of cases have blood in the stool. So anyways, you can look across these, but you'll see, we have the abdominal signs, but then we also have some non-specific signs like skin mottling, irritability, throwing up, that sort of thing, and temperature changes. We also saw those. All right. So, and then we looked at asking clinicians like what their workflow was so that we could kind of help intervene and try to make neck recognition a little bit more consistent. We looked at the processes and the data sources that people use to communicate neck risk and actions that they took. We did focus groups across 2 institutions and asked 27 different clinicians to talk to us about it. I want to highlight, this is the neck decision making for the provider, and the box around these 2 boxes highlight that they started their process of assessment and action and diagnostics, usually at the point of being notified of concern from a nurse or a parent, and that they often had to clarify the relevant details with the RN or in the EHR, but this is a kind of a problem. It's typical, but it can be a problem if they don't trust the message. So that's one of the things that we've been really bothered by as we've tried to make neck risk awareness and recognition more consistent. So that's why SBAR can be really helpful. So here's an exemplar of when neck recognition and action goes well. When I was a nurse over 2 years ago and I was working day shift and I came in, we had primary babies that we would take care of, so we were familiar with them. I had a previous 24-weeker, and I don't remember exactly the age, but I remember coming in and my report from my colleague was that the baby slept all night, and this was not a baby that slept all night. So this was a primary nurse who was coming back to take care of her baby that she had known for weeks. And she says, this baby, she was an angry little girl. And so then when we instantly took the blood sugar, and when I flipped her over, her belly was distended. So it was good to have this background. And she says the blood sugar was over 180 from 113. And then shortly after that, she had a bloody stool and she had that look. So we got the x-ray and she had pneumatosis and was down in the OR within 3 hours of my shift. So it was a little bit more classic, but it stuck with me. Remember, this is the primary nurse. And she says it stuck with her because the person who had just taken care of that baby before didn't recognize some of the things that I had picked up on, because I knew that baby and her temperament. And that's one that always sticks out in my mind. So this issue of knowing the baby. So that worked pretty well in that situation. That nurse also had decades of experience, had lots of trust built up with the physician team. And the other part of her narrative was that the other nurse had called the physician team and they hadn't acted because they didn't believe her or they thought it wasn't that big of a deal. And so it took that new nurse coming on shift, making that call, seeing something going wrong, doing some of her own actions to trigger belief by the medical team. And I think that's something that we could fix as a community. This is what I'm going to end with. Like Jennifer had said, starting this off, if nurses don't have a voice, it's very, very unlikely that parents have a voice to speak up on behalf of their NICU, of their baby. And that may be different place to place, person to person, but that's where things like discrimination and bias and selectivity can come in. We need to be more consistent. And when we asked parents about their experiences with timely recognition about NEC, they were pretty disappointed when the team didn't work together. And one of the things we found is that parents interpreted that lack of team cohesiveness as poor care. And they described it as lack of caution with NEC, delaying recognition, delaying action, poor communication, poor teamwork, and inconsistent care. And they said that when the team knew the baby and they communicated effectively and promptly, and they collaborated to solve problems and recognize NEC together as a team effort, the parents felt it had a positive impact on their child's outcome. And parents also felt that when the action taken was transferring that baby to a higher level of care, they felt like that was action. And they associated that with a better outcome. So I think that's really an important thing to close on as I pass it over to Jill. Thanks.
Thank you, Sheila. That was such an informative and engaging presentation. Thank you. So important. So we're going to be hearing from Jill, and I will pass it over to you. And Jill, if you want to share your screen, that would be wonderful.
So hello, everybody. I'm Jill. I am a nurse that works very closely with the quality and safety team in our unit. So I do a lot of QI. And this is a perfect time for my talk because it really reflects what Sheila and Nicole had mentioned earlier with their narratives of not being heard, not being believed, and some of the communication biases that we do encounter at the bedside every day. And, relationships between the medical team and nurses can really be challenging. And how do we overcome them? So I was just going to share my story, how our unit is trying to fight that battle right now. So just a brief overview. We have had very historically high NEC rates in our unit, where we have tried to do multiple quality improvement initiatives to bring those rates down. So we did implement our first NEC reduction project in 2017. However, in 2020, there was a significant trend upwards. And I am embarrassed to put this on there, but we need to be honest, right? So our rates right now in 2021 are at 23%. And that shouldn't be. And why is that? So, I came onto the quality improvement and I said, this is something that we need to reevaluate. So, this is just a run chart. I love visuals. It shows you, in 2015, we had such a high uptick of NEC. So we started our QI project, tried to get it down, and you can see we had a nice trend downwards. But then, in 2019 to 2020, and even now higher, we're upwards of 23% when we were at 21.7 in 2020. So like I said, we really need to revisit and we need to reevaluate it. The first quality improvement initiative in 2017, I wasn't a part of directly, but it was really just staff nurses working with a lead physician. We didn't have a lot of other multidisciplinary people involved. And really the neonatologist acted as a lead. And because of that, most of our process changes focused on bedside care practice, nursing bedside care practice. So, we looked on more things that what we can do as nurses at the bedside to reduce risk of NEC. But, we didn't really dive deep into any other aspect of it. So we focused more on increasing the use of human milk. How do we handle human milk as far as storage when we prepare it? We don't use a milk bank, we do it ourselves, and focusing on rewarming and different bedside practices around milk. But, maybe because we're having this uptick, those interventions were important that we were doing at the bedside. And, they did show that they were decreasing our NAC, because we did have that, that decrease for the last, from 2017 to 2019. But why are our rates rising? So do we need to expand our scope? Sheila spoke about it, and Nicole spoke about it. A lot of times nurses find that there's something not right, something that doesn't seem, something seems off with their baby. Maybe we can't quite put our finger on it. Maybe some abdominal distension, some lethargy, temp instability. Maybe they seem to be breathing, increased work of breathing, and things like that. And a lot of times we have concerns as nurses, and we call the physicians, and they don't necessarily respond. Maybe we are dismissed. Maybe some of those biases that Sheila spoke of come in. And a lot of nurses were having difficulties and frustrations, and they're saying that there's something wrong. The doctors aren't listening to me. I feel that there could be some signs of feeding intolerance, but they're not coming out to examine the baby. So these are, and they would say, let's just feed through, everything seems fine. But there was a piece missing. So we know we need to change this culture. We need to be able to have an effective form of communication, but also we really need to be able to delicately bring this up to the medical team's attention. So we all know, docs love data, and so what can we do? So how can we show them that maybe that's a sign of concern? So we did a root cause analysis on all of our infants with a NEC diagnosis, so Bell stage 1 through 3 included. So not all of the surgical babies, but just medical NEC babies we looked at. And we did them from 2019 to present. So, these findings, as we started to do these root causes, became clear that our focus on nurse practices, weren't enough. So not to go through the details of all of our root causes and everything we found out, but there was 4 risk factors of areas of change that we found amongst all of our cases. So areas regarding around blood transfusions. There was no standardization of feedings around blood product transfusions. It depended on what practitioner was on that day, what clinician was on that day, some for the MPO status. We also noticed that almost every single baby that was diagnosed with the NEC on that day, their hemoglobin and hematocrit levels were very low, and they required blood transfusion. So are we not monitoring these babies long enough? Are we not we're not doing enough blood checks to see, keep on top of the anemia? Human milk use, we were really good about using human milk and donor milk. But sometimes there were some babies that might not have seemed that they were at risk, and we would use formula. Some of the doctors weren't quick at getting donor breast milk consent right at admission. So that was something that we needed to really focus on. Feeding practices, we noticed there was a lot of discrepancy on when we transitioned from human milk to formula, as far as fortification of formula. There was a lot of inconsistency amongst practitioners. Even though we did have a feeding protocol, our feeding protocol was needed to be looked at. As somebody mentioned earlier, you should always be reevaluating everything. And that was something that we definitely needed to look into further, because we were seeing that these kids were getting advanced so quickly. So maybe we need to draw that feeding schedule out a little bit, the feeding protocol. And then again, I think the most important thing that we really needed to focus on was communication and standardize our language. Nurses alerted the medical team to signs and symptoms of feeding intolerance multiple times. We saw on the root cause prior to even obtaining a film. So, some providers we saw would give maybe a day of bowel rest, 24 hours, or even till the next shift came on, and then that practitioner was like, no, let's restart feeds. And so, you know, that was a lot of inconsistency as far as, okay, we've gone bowel rest. Do they restart? Some of these kids were restarted on full volume right after bowel rest. Some of them were on half and then full. So we did see a lot of discrepancies on that. So, you know, there's more to this than just nursing bedside care practices, obviously. And like I said, the lack of communication between nursing and the medical team really stood out. We needed to find a way that we could convey our concerns and also build trust. And, you know, as Sheila said, that's bias free. We're all there for the babies, and we all have the baby's, you know, outcome in our minds. But, you know, it was unfortunately, I hate to say this but it was a lot of an us versus them. So a nursing versus the medical team kind of environment. But we needed to change that culture because, you know, the nurses believe that the doctors were almost placing blame on nursing for why we were having all these high neck rates, but they weren't looking at other factors that could be causing it. Again, like we had a lot of conflicts in risk factor management amongst the medical team. You know, everybody really looked at things differently. So how do we standardize that? And then how do we build a culture of trust and be able to communicate freely about our concerns for these babies? So, you know, I'm just going to show you, I'm not going to go into detail, the original key driver diagram that was done in 2017, where you can see, you know, we really did focus primarily, if you see a lot of our secondary drivers, everything was really around nursing bedside practices. Yes, there was antibiotic stewardship. We had a whole QI initiative on antibiotic stewardship. So that was pretty much set in stone prior to the start of this. But, you know, you'll see everything really goes around, you know, ways to improve gut integrity and limiting bacterial contamination around, you know, nursing practices. So this is something that, you know, really stood out to us that, you know, we need to add more. So here's our updated key driver diagram. And so I added a couple change concepts with ways so we can kind of keep ourselves on track. So we needed change concepts that we could bridge the gap between nurses and the medical team. And one of the main things that really stood out to us, and it speaks of what Sheila was talking about previously, is we did need some kind of a scoring tool to place non-specific symptoms into context and in a way that we can communicate clearly about early symptoms to support early recognition, because that seemed to be an underlying common theme during all of our root cause analysis. And so the biggest battle was trying to find a scoring tool that everybody agreed on. Our unit is very familiar with scoring tools and scoring systems. We have a large NAS population, so we rely on NAS scoring systems. Our unit really is based on algorithms. We have a lot of algorithms for other things that we're treating for babies. So it's something that we are familiar with, and it's something that we really do well in utilizing. So one thing that we put in right away that I think was the most challenging for nurses is that a few years ago, for some reason, our unit got away from taking abdominal girths. And, you know, some of us were rebels and we did an abdominal girth anyway, but that number's arbitrary. If I do an abdominal girth tonight and they didn't have one done for 3 or 4 weeks prior, then that means nothing. But that is something that we are trying to do. We are implementing abdominal girths. That was the first thing. And I think that's very helpful to the physicians. And it was a lot of talking to, because they felt if they're doing abdominal girths, they're going to be told that they need to, that they're going to be called more, because we're going to keep calling them and saying, hey, the girth's up by 2, the girth's up by 3. but we assured them that possibly maybe if you have GERS, you might have less neck scares or less imaging being done because, hey, sometimes I come on and I say, wow, that belly looks huge. But if I have no measurement to go by, how do I know, is it just visually big or is it measuring the same as it had previously? And, they're like, oh, so you think it might cut down on how many times we're taking films and we're doing follow up on these babies? And I said, absolutely, it would standardize. So they liked that. So we had to figure out a tool that worked best for our unit that could accurately discriminate those infants that are at most risk for neck. And then hopefully that would heighten awareness of neck risk. And, we could probably try to tailor and have more of a standardized care practice for these at-risk babies. Perhaps do a slower feeding advance, be more cautious of fortification, donor breast milk usage, and things like that. And so this was something that took a long time. And we felt that this is a great way to provide a universal language and provide prompt treatment. So we decided on our unit to go with the ENEC tool, the neck risk scoring tool we chose. We did discuss other tools, but the gut check neck tool was one that a lot of the nurses favored. But the physician team was a little bit hesitant because, and we all know, reading the research, that units that have higher rates of neck have higher chances of babies have higher risks of neck for their infants. But if you look at the gut check neck score, when you have high rates of neck like we did, it automatically gives a lot of high risk score for almost all the babies. So that was a little intimidating, I believe, for the docs. So we compromised. And this particular tool was of interest to the medical team because it took into account a lot of maternal factors that would heighten the medical team's awareness of neck risk. We have a really high, I spoke earlier, we have a really high drug use population. These moms usually go without prenatal care. And there's other things in our in the tool that really fit well with the population dynamics in our unit and the moms. So that is why we went with this tool. We are working on continuing with trying to establish a standardized algorithm and for fortification and restarting feeds after bowel rest that I spoke of. And the doctors are now that we're talking and we're all coming to the table as a team, multidisciplinary team, we have nutrition, we have pharmacy, and nurses. I think we've really built a good level of trust and communication, because we all have agreed that these rates need to go down and we have a problem. And I think, once we presented the medical team with the root cause analysis and they're seeing this, I think it really brought to light some of the issues weren't just around bedside care practices, but it indeed really was around some of the other, issues of communication. And it's simple to fix. This tool that we're hoping to use should be helpful, because our nurses with QI initiatives in the past, it really ignites a spark, and they get really excited. And we've made so many major advancements in other areas where our unit was falling short. And we really improved patient outcomes. And I think when when we display all of our QI on our unit, our results, and people can see the changes that are being made every day because of us, the nurses that are at the bedside, you really take ownership and you feel empowered because you know that you can bring change. So we are going to be rolling this out, this new tool and education in July. So, you know, I'm really hopeful that this will really open the doors for communication between doctors and nurses and just break that culture that we were having in the unit of an us versus them. And we can collaborate and work together, you know, to have a world without NEC. And, you know, I was very, to think that I can bring the rates down, or we in the unit can bring the rates down to less than 8%. You know, we can, I know we can. We've done it before with other QI initiatives. So, you know, I just want to thank, you know, Nicole for mentioning how important it is to hear a mom's voice and for the parents to be heard. And that's something that we really advocate on our unit. So, you know, we talk about it, we call the docs and say, hey, mom thinks the baby looks a little off today, you know, and they do take that very seriously. And, you know, and that's something that that we have as a culture on our unit to really incorporate the parents in with our QI and have them be a part of our plan of care and everyday conversation. So, but thank you for having me and allowing me to discuss the hard, kind of sensitive topic that we had.
Thank you so much, Jill. We
You're
really
welcome.
appreciate you sharing your story. Thank you so much. We're going to hear from Adrian now. I'm going to turn it right over. And Adrian, if you'd like to share your slides, that would be great. Thank you.
All right, and thank you so much for allowing me this opportunity to present. I'm going to talk a little bit about long-term outcomes of NEC and how RNs can make a difference. Again, my name is Adrienne McIntyre. I am a member of the Kaiser Permanente Northern California Patient Care Services team. I also am one of the board members of our Northern California chapter of NAN. So thank you, Jennifer, for hosting us. I have no financial disclosures or conflicts of interest related to this presentation or educational activity. So this quote was taken actually from one of the very few articles describing the long-term outcomes of NEC written by Vazulchi, Liu, and Nicu. Necrotizing enterocolitis remains the most threatening gastrointestinal complication of prematurity, leading to high mortality, morbidity, and cost. And I think all of the presenters today really were highlighting some of the challenges that we all experience in managing NEC in our NICUs. I love the focus on recognition. We've had so many things talking about our abilities to create context with regards to quality improvement from Jenny, and really highlighting the need for culture work. Mindy talked about some of the evidence practice bundles that can be implemented utilizing mother's own milk, colostrum feeding protocols, and early skin to skin. Sheila really talked about timely recognition and our risk factors. And then Jill just highlighting her unit's quality improvement projects. And what's really fascinating when I look at the long-term outcome data with regards to NEC is prior to 1972, the survival rate was only 17%. Subsequently, in an article published in 1981, so yes, it's 2021, so we're talking 40 years ago, we rose the survival rate to roughly 68%. But what's shocking from this last 40 years is the survival rate, particularly in the surgical NEC category. So those are those higher bell risk scores with regards to NEC, or excuse me, category scores. We're really only in the 70% range. There's a few articles that maybe got us into the 80s. So that change from 1981 until today is not huge. And then with that increased risk of survival, though, is really related to our abilities to have these standardized protocols, early recognition and treatment, and our overall ability to provide physiologic care to our critically ill neonates. And so just again, really wondering, okay, well, where do we go from here? We focus so much on survivability, but what does that look like? And so we've been highlighting some of the the various types of neck, medical versus surgical. So is this a watch and monitor and treat with antibiotics? Is this a patient that goes on to need a surgically implanted drain? Or is this patient one that goes on to require surgical interventions in bowel resection? And at what point along the path does that occur? So is it a surgery now or a surgery later? Either way, we know that most of these patients require lots of lines, tubes, and drains. So we're talking about central lines, often for antibiotic management. We're talking about the placement of not just Penrose drains or tubes related to treating the short-term neck presentation, but a lot of these patients go on to need gastrostomy tubes and other types of feeding tubes long-term, and then those surgical drains that we were talking about. And then as a result of the processes that are occurring in the abdomen, we have a lot of high risk for adhesions, obstructions, need for surgical revision, strictures, and then ultimately, if they had a colostomy, ileostomy, duodenostomy, wherever the infection occurred, there may be an opportunity for surgical takedowns of stomas and mucus fistulas, and then hopefully reanastomosis of the bowel. So really, there's an opportunity for the RN not just to talk about the ability to recognize neck, but maybe to highlight in the event that neck occurs, what can they do to support the family in preparing for the course that's ahead. And so really just understanding that this may not be a one and done surgery situation, that for most, this may be just the beginning of many more surgical interventions. And so how do we draw the family in to promote parent involvement with some of these interventions, such as tube feedings and medical devices early on to help them transition to their home care experience? So I was starting to touch on some of those complications. In the literature, what we're finding is in the short term, of course, our biggest concern is survival, right? So mortality being our biggest short-term complication. But because of this kind of global inflammatory process that happens with necrotizing enterocolitis, it's basically an abdominal compartment form of sepsis, and it has a high risk for causing widespread inflammation throughout the body. And so what we see, especially in our extremely low birth weight infants, is this is a patient population that's already prone to high rates of poor neurologic or neurodevelopmental outcomes. And this presence of this vast or widespread inflammatory process, they're thinking can contribute to increased risk of intraventricular hemorrhage, periventricular leukomalacia, lung disease like chronic lung or BPD, bronchopulmonary dysplasia, increased risk for patent ductus arteriosus. That's a little bit of the chicken and the egg. Which came first? Was it the PDA or was it the neck? Increased risk of ROP, likely due to their need for longer-term ventilatory support and oxygen support, and then poor growth. And then in addition to that, we see things like evidence of short bowel syndrome, particularly with resection, surgical intervention. That can lead to dysmotility of the gut, as well as strictures or adhesions. Long term, we do find that in our high-risk infant follow-up using developmental scoring, that survivors of NEC do have a higher rate of neurodevelopmental impairment, as well as poor growth longitudinally, and that's both weight as well as height. And again, we know that preterm infants are prone to poor growth with regards to weight and height, but this is exponentially worse in the NEC surviving population. In addition to that, just GI alone, though, we're seeing evidence of, again, short bowel syndrome, dysmotility of the gut, adhesions, intestinal failure, including malabsorption abnormalities, which we're seeing as many as 11 times more likely, 47 times more likely in the 6 to 12 month range, and 62 times more likely in the 24 to 36 month range for these patients to have malabsorption, and that may be what contributes to their long-term poor growth. We see cholestasis and liver disease, likely due to long-term TPN, parenteral nutrition, and then feeding difficulties. And I think the feeding difficulties one is, potentially really underestimated. We have some literature showing that we may see 11 times more likelihood of feeding difficulties in the 6 to 12 month range. And I think Nicole talked about that. This is that baby that suddenly spits up with any change in their diet, doesn't transition well to solid foods. If they do transition to solid foods, they have dysmotility and that malabsorption playing a role in their inability to digest those solid foods. And then long term, what does that mean in terms of their oral motor skills? These are all questions, though, that are still out there because the literature in this area is just so skim. And so really just highlighting the fact that in our surgical neck patient population, strictures occurring in our surgical and medical neck up to 65%. And if you have 65% rate of strictures, that means that there's high likelihood to need to have repetitive bowel surgeries. And so what does that mean? And then just really, really digging into what's the nurse's role in having conversations with the family, bringing them into the discussion and looking for opportunities to really build them up, highlight the need for mother's own milk, but also in a way that says, if you're at a high risk for dysmotility, adhesions, or intestinal failures, what can the mother do for her diet to potentially eliminate allergens out of her breast milk to promote better absorption or better feeding tolerance in these patients? So, really kind of trying to dig into looking at this concept of neck as abdominal sepsis and that impact of this widespread inflammatory process that's happening concentrated in the abdomen. The part that's kind of missing is the focus of these complications is really related to neck itself, right? So, we talk a lot about neck in the sense of we had neck, and so we're looking for evidence only in the infant period related to our ability to grow and develop the neurodevelopmental skills for feeding, coordination of suck, swallow, and breathe, and transition to oral intake if possible. But these infants really are going to benefit from close follow-up, looking for early diagnosis and treatment of some of these other complications. And so I really feel like this is where nurses that are involved in programs such as high-risk infant follow-up programs, GI specialty clinics, surgical clinic nurses, those that really focus on the role of case manager and care coordination, they are really going to be, I guess, for lack of better words, our secret sauce with regards to filling in the gap here with our research and advocacy work as a nursing profession. We're finding that, those that really start to have severe complications such as intestinal failure, they're going to need a multidisciplinary approach that involves careful assessment of their growth, their ability to absorb nutrients, looking for signs and symptoms of things such as bone demineralization, their neurodevelopmental outcomes, and how can we really optimize those on behalf of these neck survivors. And then this is really what's going to build up our ability to support our patients and our families long term. Right now, just going through the literature, majority of the data is limited to the 3 to 5 year span. And a lot of that has to do with the fact that the neck survival data is coming from high-risk infant follow-up clinic type data, as well as assessment of Medi-Cal or Medicaid payer data related to extremely low birth weight billing codes. And so what I'd love to see as nurses really embark on this journey of research and advocacy is to draw in some of these specialty care case managers and case workers into the NICU environment, because we want to do the best that we can with regards to recognition. But there's a huge opportunity with regards to how do we manage the long-term complications. And just in reviewing patient stories, I think there's so much for us to learn from stories like Amari's that Nicole has highlighted, and the impact of NEC on her long-term relationship with food, her GI discomfort, her presentation that may mimic irritable bowel type symptoms. There are lots of parent advocacy groups out there highlighting the long-term complications of NEC, like the NEC Society, but there isn't a lot in terms of the nursing literature and research. So I'm going to use this last moment of mine as a call to action for all of you to consider if you can draw in your patient families in terms of patient advocacy, or maybe even a parent-focused group to help inform not only how you advocate or you communicate in the moment with regards to NEC, but how do you prepare them for long-term success, because it's still to be discovered. Thank you so much.
Thank you. That was a fabulous and much needed presentation. Thank you for reminding us of the need for long-term care and support for our NEC patients and families. We're going to quickly go over some engagement opportunities. Here are a number of projects that the NEC Society is working on. I just want to acknowledge that I know the NEC Society is going to be becoming more and more intentional about elevating nurses in their roles in our various projects. So I just wanted to highlight that quickly. And then if Erin would be so kind as to share the link to our poll in the chat box, just quickly, if you have a chance, ways that you would like to be involved in the NEC Society. Are you interested in sharing your story? We have a link where you can easily do that. Would you like to attend webinars, more webinars, advocate at the state and federal level? We've talked about hosting NEC Advocacy Days. We haven't actually hosted one yet, but we're planning to and hoping to in the near future. Participating in our virtual and in-person meetings or conferences, donating, and other ways to get involved. So we would love to really elevate your involvement with the NEC Society. I'm going to move to the next slide. Another question I have for everyone is, what resources would you like to see the NEC Society provide? I know you were introduced, or maybe reintroduced, to a number of tools and resources today. I think the NEC Society could do a better job of elevating those resources and those tools on our website. I know we would love to create a page really dedicated to bedside nursing tools on our website. So just a couple of ideas. And so if you have a chance to either answer this question now, or you could email us at a later point, we'd love to hear what resources that you would like to see us provide. I'm going to advance to the next slide. I also want to acknowledge and really highlight this amazing podcast that Jill, who spoke and shared her NICU story with us today. She's the host of the NANcast. It's a podcast for NAN, and Sheila and I have both participated as guests on this podcast. So we encourage you to check out the NANcast, check out the two podcasts that you see here on NEC prevention and NEC awareness, and really continue to follow them. Great podcasts. And finally, just some quick ways that you can get involved with the NEC Society. You can share your story. As you heard today, they're very powerful, compelling ways that really demonstrate the urgency of the work that we're doing. You can help us raise awareness, telling others about NEC, why this work is so important. You can start a fundraiser. You can stay connected with us. We're on social media, and you can also donate at necsociety.kindful.com to support our vision of a world without NEC. And if you have questions that you see at a later time, you can always email them to myself, Jennifer, at necsociety.org, and then we can make sure that we get them to any of the speakers that you would like to connect with. If you have any future topic webinars that you would like to see us spotlight and feature and address, we'd love to hear from you. So you can either answer here now using this live poll, or you can again email us at at jennifer@necsociety.org. I'm going to advance to the next question. And Just highlighting briefly our upcoming webinars. We have one on July 9th and another on August 20th, focused on donor milk advocacy and advancing equity. So we hope you'll join us for those. We have a great lineup of speakers. So just wanted to say thank you so much for taking the time to join us. Thank you to our incredible speakers. Thank you to Engage, Grow, and Thrive. And we look forward to hearing from you soon. If you have a minute and you would like to take a quick poll to give us some feedback, we'd love to hear from you. So thank you so much, everyone. Take care.